All right. Hello, hello. Welcome,
Oh,
everyone, to another episode of Healthcare AI Podcast. If you're on that, or Converting Descent Podcast, welcome back. And I have with me my trusted co host, Alex Thomas. Alex, hello. How you doing?
all right.
Yeah.
Nice summer day. How are you?
Get, yeah, I'm doing good. Getting ready for the move cross country.
Yes. Yeah.
For those of you who don't know, Alex is moving. He's in Florida. He's moving all the way back to Seattle. Yeah. So
Mhm.
we're looking to have him back. Uh, All right. So, Alex, what are we going to be talking about this episode?
Yeah. So I found this interesting survey paper about LM agents in medicine. The name of the paper is a survey of LLM-based agents in medicine. How far are we from Baymax? Um,
And for
uh,
those of people who don't know Baymax, maybe just give a little intro to what Baymax is.
yeah, I think the movie is called like Big Hero 6.
Yeah,
Yeah.
yeah,
And if you remember any of that, there's a sort of balloon robot that does like medical stuff. The famous clip is him petting a cat as he's low on battery, going "Harry, baby."
yeah.
Yeah,
And so the intent
yes,
of this in this robot, like the student, he's working on this project. He's trying to build this medical robot that can basically would diagnose anything and try to fix most common medical conditions, right? That is at least the original intent of the project Baymax.
yeah.
Right. Okay.
And
Okay.
the question is like, how close are we to something like a TV or movie idea of medical AI?
Right.
Um,
And
so
so maybe we'll just start at the beginning. So what are like LLM based medical agents? What are they capable of now, and like how are they different than just regular agents?
yeah,
What's the deal? Yeah.
so some of our listeners may know what an agent is, opposed to just using LLM model directly. For those who don't, an agent has the ability to perceive its environment in a way, and more importantly, it can make plans and use tools. So when you interact with, let's say, ChatGPT,
Mhm.
um, ChatGPT, if you ask it a particular question, it can decide to go search the internet, or it can decide to run a other particular tool that it has. So ChatGPT is an agent. GPT 4.0 mini, let's say, that's just a model. So that model in and of itself doesn't have like tools or the ability to access a database or something. That's just a model.
Mhm.
A lot of basic applications up until now, I guess maybe last year or so, um, they've been just models. So like a lot of applications, that's, oh, you calling a model, get a response, and get back. But over the past year, a lot of people started building, I guess maybe more than that now, start building agents. So these agents can do a lot more complex things. And as you get sort of deeper into the paper, we're going to see that you can also orchestrate multiple agents to build a very sophisticated system.
Mhm. Cool. Well, so getting into the survey because it looks like we're going to be talking more about it. Tell me about like the survey paper itself. What kind of how broad was it? What does it cover? And like maybe just give us a overview of it.
Yeah, so it covers 60 studies, and it breaks it breaks the different systems that are analyzed into different categories based off of system profile. So that's like um, how the agents were specialized. So it's often the case that agents they're not necessarily built with like ChatGPT is a super general agent. Most applications, if they have an agent, it's going to be very specialized to a particular task or set of tasks or a particular domain of knowledge. Um, and so the system profiles are how it's specialized. There's its ability to do clinical planning. So that's sort of the logical design over how you either give it iterative prompts or chain multiple agents together in order to get a plan to satisfy the user input.
Mm.
And then there's the medical reasoning, which is again like how it's structuring the reasoning process. And in the paper, they refer to as external capacity enhancement. It's access to data. So
Okay.
yeah,
Or tools or data or so basically the whole okay MCP type stuff. Okay.
EMRs accessing medical images, etc.
Okay. Okay. That all sounds like great. We should probably and then we'll
Yeah.
spend time like diving into each of those. But before we do that, I want to talk about why this matters now. Like, what is the urgency around like AI in healthcare, and LLMs in healthcare? Like, and maybe just set the context for us in terms of where the industry is and how AI is going to make a difference, or and then yeah, just let's talk about that. Yeah,
Yeah. So everyone knows I think there's strains on a lot of medical systems around the world, but both of us are here in the United States, and we know that the American healthcare system, has problems, and being short staffed is definitely one of them. Having some areas that are under resourced, so if you live very in a very rural area, you may not have access to a lot of medical care, and especially not access to specialized medical care. So
yeah,
that's like one of the issues that you maybe if you live in like some rural town in Montana, you'd probably find a general practitioner. You'd probably find a general practitioner, but finding an experienced oncologist might be difficult.
yeah. But I almost think of it as like a perfect storm, like healthcare is going through right now, which is the policies of the new administration in the U.S. at least, where their policies are affecting labor because people don't know this. A big percentage of labor for healthcare actually comes from immigrant labor,
Yeah,
and so their policies are directly affecting the healthcare industry in that sense. So from a labor perspective, back to the labor shortage problem you're talking about, and then the other end of it is funding, right? And so obviously a lot of the funding comes from government, Medicare, and and so on, and those are being also cut, and so as a result, funding is being affected. Labor is even becoming harder, and then you think about the demographic shift that the U.S. is going through, just like a lot of Western countries, which is populations are getting older, right? And so they're going to require more services, and so if you add those three things together, you have a perfect, recipe for a crisis that's
yeah.
brewing.
And this crisis can actually then very easily extend to even other parts of the economy, with a lot of the investment money that's fueled a lot of like recent booms coming from baby boomer retirement funds. Well, as baby boomers run into medical problems as they're aging, that money gets pulled out of the investment market and it goes into paying off healthcare. Yeah,
So that makes yeah. So clearly, I mean, those things would definitely looks like healthcare is heading to a
yeah.
crisis. But so how can AI make a difference? So what is and how is it going to help? Will it help, or what is the yeah? What's your take on this?
So I think that like, there's two ways I think, or like, I guess there's three main ways I think about how it helps. One, it can improve overall availability, because availability is not just geographic. There's also socioeconomic limits to it.
Hmm.
Um,
Hmm.
there's also, like, as you mentioned, with the aging population, there's going to be a lot of people going in there with similar problems. And right now, with a lot of the ways that the government money, let's say like through Medicare, can incur a big paperwork cost on providers, AI can really help alleviate that paperwork cost. Um,
Mm.
and then finally, patient communication. Um, that's a really difficult thing, I think, even for like humans to do. But the reason why AI might be able to help is that it can. The thing that LLMs are good at is understanding the statistics of our vocabulary.
Yeah.
So if you successfully build your prompt and do your fine tuning, you can build a very effective model that can explain things in different registers, so different like styles and formalities of speech. Um, and that could mean that the patients get better information about what they need to do or what they need to understand for their conditions.
Right. But that all sounds great. But as we all know, medical the industry and healthcare industry is definitely different.
Yep.
and there has to be certain. I'm assuming certain changes made to regular AI. Like you can't just put ChatGPT in front of a patient and be done with it. What what
Yes.
what needs to change in the AI, how we deliver AI in this industry and context? You think?
So there's several regulatory and technical hurdles that do need to be handled. Obviously, we're dealing with sensitive information, so all this work needs to be done with that in mind. That you want to be, you want to have all you want to be compliant with all the regulations around HIPAA, um, and you need to be sensitive with the data. Um, you also there's a lot of skepticism from people, but also from institutions about AI. So people need to be aware that regulations are here and more are coming as lawmakers learn enough to implement regulations. Even though maybe not enough to understand the regulations they're putting in, um, but the regulations are coming. So there's that aspect of it. Then, as you mentioned, you can't just put ChatGPT in front of a patient, or for that matter, in front of a doctor, um, because if you don't have any sort of specialization of your system, then the data that it's trained on may not necessarily be the data you want it using to answer the patient. So you want to make sure that it's accurate, and that it follows whatever sort of procedures and requirements you need to do. So, for example, if you have something that's supposed to, if you have a system that's answering questions about prescriptions, you don't want it to give advice, because they should always contact the provider or the pharmacist for any sort of questions about how they take it, when they take it, or any details about that. It can answer general reference things about the prescription, but you don't want it saying, "Oh, you can skip this dosage" or something like that.
Right, right. So you can't really give like what is termed as medical advice, right? Or like
Yeah,
what is yeah? I mean, I don't know what the how technically what is that line where you shouldn't cross. You seem to be indicating there is a line there, but yeah, we'll get into that later, maybe.
yeah. So that line is like linguistically, it's probably a little like linguistically, I think we can conceive it a little clearer than we can in a legal sense. Funny enough, so like linguistically, as long as it's not talking about the patient's specific, their specific use of the drug, it should be fine. But once it starts saying like, oh, you know, you could take like what the patient can do. Oh, you could take 2 pills, or don't take this, or you can take that.
So
These the
it can't prescribe stuff.
Yes.
It can. Okay. Okay.
It can, and even if let's say you look for interactions that it has, so those could be listed, let's say, in a database.
Mm.
So if a patient comes along and says, "Oh, can I take Advil with this with the drugs I'm on?" It can say something like, "Oh, Advil is not listed as one of the drugs that has a interaction with it, but you need to make sure it also says, please consult your pharmacist or provider."
Right. Right. Right.
Um,
So it's I mean, yeah, in a lot of sense, it's similar to like looking up like stock tip advice or
yeah,
like details about financial industry, and there's always this caveat that well I'm not a qualified financial advisor, so please consult your own.
yeah, and that's an
So
interesting UX aspect of it. You don't
mhm,
want your model to respond like it's a person.
right,
Because, for example, in Europe, there's specific regulations that say your system can't do that in general, let alone for a medical
right,
context.
right,
The person needs to understand they're always working with a very fallible system.
yeah, like there's more and more studies coming out around this, and especially in countries where there's not a lot of access to good healthcare, people are relying on these AI models as a proxy for their primary care provider or their physician or whatever the healthcare provider, right? Because oftentimes, even in really poor countries, most people have like a phone that actually has access to the internet, uh, and so they may not have access to a healthcare facility, or right, but and so whether or not governments are trying to regulate this, I just want to point out like that we're not going to be able to stop people who don't have any other access or any other means from relying on these AI models as their only source of healthcare guidance and our advice, even, right? And so they're going to try to force the model to do the things that the governments don't want them to do, and
Yeah,
try to keep like prompt hacking to see have it like jailbreak and see if it can give me the advice that they're looking for, right? In a way, because not maliciously, but because that's their only way to get
yeah.
that kind of advice. So yeah, it's yeah,
And I think that sort of where we're at now, I think we're very much in the baby steps of developing these systems, um, especially because we're still a bit fuzzy about this the huge ability of the huge amount of capabilities unlocked by the training volume and model size of LLMs. We're still learning about that, and so that means for its use in like medical, we're still learning. Like, hopefully, we get to the point where like a government or some nonprofit can make a free available model that is actually safe and reliable for giving advice. Um, but
yeah,
people look for that advice, but then there's also like these stories of um, you know maybe it wasn't in a medical context, but LLM-based systems advising people to harm themselves. Like there's some stories where like
yeah,
someone has like
yeah,
a virtual girlfriend, and they get told to harm themselves, and then that comes to
yeah.
pass,
So
and that
speaking
means
of
that, yeah,
which, maybe let's get into like some of the details around the architecture of such agents, medical agents. And you brought up a point about like personalities that these agents are starting to develop, and like so from a medical agent perspective, what are the different like approaches to sort of dealing with these medical agent personalities, right? Like as you said,
yeah,
hey, they are becoming a proxy for in a lot of places for a healthcare professional.
yeah.
And so how does one, an organization that's thinking about incorporating AI into their sort of customer facing, patient facing experience, how do they actually think about this? What are the different approaches that you can take around thinking about this personality that your medical bot or agent should take?
So I would say the way people want to think about this is that there's two sort of opposing interests you have. One is the vast capabilities of these language models, and two, for any sort of domain or use case where you need safety or some sort of restrictions, that means you need to go the opposite direction. So you want to have as many restrictions as possible, but still support your intended use case. So
Hmm.
any way you can constrain your system without losing the capabilities you want. That's the design guideline. So
Gotcha.
yeah,
And how do you break up like in terms of the whole
yeah,
system itself? How do you think about like sort of organizing the system and this AI overall AI medical AI system itself? Like what does the paper talk about? I guess.
yeah. The survey talks about three ways of doing that. One
Hmm.
is you break it down by the tasks that the agent is doing. Now that's I tend to like personally that one because being from a software background, breaking things up by the tasks they're doing is sort of a
Hmm.
natural way of decomposing problems.
Hmm.
Also makes it very easily testable because then you can say, oh, I can test for this task and this task and the other. Um,
Right.
for the other way to talk about it is splitting up by role. So that
Mm.
is, if you
Right.
think of the people that it's supposed to be helping, if you think of like your user profiles, you're like, oh, I
Yeah.
want an agent designed for helping this user or this kind of user. So
Mm.
maybe you have one that's built for a cardiologist, one that's built for a patient, one that's
Hmm.
built for perhaps administration or want to look at population. Um,
Yeah.
and then you have the departmental one. So this is where you specialize by domain of knowledge. Um,
Right.
so you can
Yeah.
have one that maybe knows about genomics, or one that knows about I don't know pediatrics.
Yeah. But when you're talking about these, I mean, I think two and three are largely interchangeable. Like because you have a cardiology department in a hospital, and so. yeah, there might be a cardiologist, but then there's also a department. I'll go with that, and similarly. So yeah, and I think the functional breakdown to me makes sense
Mhm.
at a task level, but I think of that as more of like a low level breakdown, and then you build these sort of specialized agents, and then
Yeah,
maybe there's a higher level uh, that's more closer to like the user, where the personality starts to evolve, right? Like that's where you could have like a departmental or role based agents that have a
yeah,
specific personality, but they still sort of work with these sort of low level task based agents to get stuff done. Um, to me, at least, seems like a good organization or a architecture of these sort of agents.
yeah.
I don't know. So
I don't think of these as like they're as exclusive to each other. I agree with you. I
yeah.
think from a software design point of view, you have to do the first one, functional modularization. You have to do that just for testing, just for just for the software logic. For the role and departmental stuff, they have obviously a lot of overlap in what they're doing, but there are some roles. So, for example, like I said, hospital administration or nursing advice, where
Mhm.
it's actually very broad across domains.
It's cross domain. Yeah, yeah, yeah,
Yes.
yeah, and
Um,
yeah.
yeah.
That makes sense. Yeah, and there's going to be cross cutting roles
Yeah.
for sure. It's definitely an interesting problem of how you want to think about your agent architecture, if you will, right?
Yeah.
Like, and then as a hospital or healthcare organization, this is something that I think most of these healthcare organizations have to sort of start thinking about. How do they want to define their agent architecture, and what does each agent do, and like what are the constraints, what are the requirements, what are the tools that each agent will have, and the bounds and limitations, and there's going to be a whole bunch of specifications that you're going to have to start defining for these agents even before you start building them. So that's going to be an interesting um,
It's a little bit
systems
reminiscent to me.
engineering problem. Yeah,
Yeah.
good. Yeah.
It's reminiscent of me of our previous work that we've done a lot of knowledge graphs, which is like one of the things that makes a knowledge graph different than like a traditional database is that the structure of a knowledge graph is informed by the domain,
Mm-hmm.
as opposed to being separate. So, like with a relational database, right? You have normalization. You structure the data based off of basically the different retrieval patterns, etc. The domain is not as informative in the actual database structure. For knowledge graphs, it is, and that means that the data design does need some domain expertise. I think it's the same with designing these agents. This is different than like building, whether you want to analogize it to microarchitectures in the past or
Yeah.
to like previous generations. Like when you build let's say you were building like a microarchitecture to support a clinical decision support, you would probably not need to involve a physician in how you're going to design your microarchitecture, how you're going to decide, what are the different services you're going to support, how are you going to deploy them. No, they just need to know how it looks like at the UX level. But for these sort of agent ones, you do probably want to get some user feedback on how you're building your agent workflow.
Hmm. Hmm. Yeah. Yeah. In a lot of sense, it is similar to like past architectures, like service oriented architecture or microservices, like you said, things like that. And but in some ways, it is obviously very very different. The user experience layer is to me is the most tricky one, just like every other user
Yep.
experience layer.
Yeah,
And of course, in this case, the experience is just it's conversational, and so it's much less about what you see than
yeah,
the personality of the agent and what kinds of capabilities do you want to employ the agent with at the end user level that's going to be
yeah,
interacting directly with your users, right? And so
yeah.
yeah. um,
But as you're saying, as far as about like how do you actually do the breaking down of these tasks, um, uh, so the paper they go over some different approaches. Obviously, there's the not breaking it down and doing like a single agent to support a chain of tasks. And I know that a lot of newer models they are trying to train them so that you can give a single prompt with a chain of tasks in it, and it should perform well. And maybe they'll do better. Maybe they'll even do better than a chain of tasks. But there's a fundamental problem in doing it with one prompt. You cannot test the individual steps.
Right.
I mean,
Right.
you can get it to try and surface its intermediate results, but that's still a lack of visibility you have into it. So I still
Yeah.
think from an engineering point of view, breaking tasks down into a chain of different calls is going to be give you a better ability to test.
Okay.
Uh,
And yeah, to talk more about that in terms of like the planning and the breaking down tasks,
yeah,
because there's going to
so
be a lot of complex tasks that you need to
yeah,
handle. So, what are the different ways that the paper talks about can be done
yeah.
around this?
And this is specifically why I said that you might want to involve the subject matter experts in designing this, because they'll be able to tell you how this task is done. So that can tell you like how you might need to break it down. So one is sort of like the obvious way of breaking it down. You break it down to a sequence of steps. Um,
Mm-hmm.
so that's they call the sequential task chain. Then
Mm-hmm.
there's the
This is
collaborative
what
experts.
most agents do nowadays, right? Like they just do this by default, like and frameworks like LangGraph and all of these.
Yeah.
They help you do this. Okay, good. Yeah.
Then there's collaborative experts. That's where you have different agents that are specialized in different ways, but are relevant to the task. So we talk about the way of of specializing agents with like role specialization. So maybe you have someone with like lung cancer. Well, maybe you have an agent that's specialized around oncology and one that's specialized around the lungs. So you could potentially have them both offer feedback on a particular question that's been given them.
So this would be like in the hospital, like you go into the
Yeah,
emergency room or you get a minute, like, and then they try to bring in specialists to sort of collaborate with the emergency physician who's actually attending to you and saying, oh yeah, we're gonna run these tests and like we're gonna bring in the specialist and he's gonna look at it and he's gonna offer us advice and then of course they keep doing this as depending on your condition and whatever specialist you're gonna need. So this would mimic a more real world sort of
yeah,
scenario, but yeah, a lot of questions about like the veracity of these so-called specialized agents and all of that. But yes, um, yeah. Mhm.
and that's
And
what
then
I'm
it would
talking about.
avoid the problem
Yeah,
of having one single agent, and the bias is that the single agent is sort of embodied with and its limitations and how it was trained and whatnot, right? And so this allows you to sort of have these specialized agents and then hopefully make sure that in within their domain that you can verify that the advice that those agents are going to be providing are within the bounds of what is acceptable.
yeah.
Yeah. Yeah.
And having these multiple agents. So, in some of the things I've done out, even like outside the medical context, I found it helpful because um, there's certain types of communication that models can be biased towards, and there's been a lot of like, at least I've noticed recently, of people talking about the models being sycophantic. So, they tend to like, they're seeking to please the user as opposed to give accurate, useful, safe responses.
But also I want to say, isn't that the whole point why they train the models that way with the reinforcement learning and whatnot to sort of pick the answer that's going to be most acceptable to humans, and create these reward functions and whatnot. So I think now we're saying, oh, it's actually doing its job too well in some sense,
Yeah,
which is ironic.
it's just like with like back in the search days with it's because this is the relevant answer.
Mm.
Well, turns out relevance is kind of fuzzy, and we don't want only the most relevant things because I remember back in the day before they started doing a lot of like improvements on the diversity of results, you would end up getting like there's a point where you get like the Wikipedia result, and then you get like 8 websites that like copy Wikipedia and just have advertisements.
Mm-hmm. Yeah.
And like they were the more relevant results because they were as relevant as Wikipedia was. But those are it's relevant, but it's also worthless. And so if it's too sycophantic, let's say someone's asking a question of like, oh, I just had heart surgery. Is it okay for me to go kayaking? You don't want the model to have a bias to say yes.
Right.
You
Right.
want it to give an honest answer, which is maybe hold off. Um,
Maybe try not to please the user all the time,
yes,
especially in the medical context. That's so important because, yeah. what might be pleasing to the user in the moment may not be what is actually good medical advice,
Yes.
and those two might actually conflict, as we all know when we go to talk to our physicians about what we cannot do and what kinds of food we can eat.
Yeah.
The doctor is probably not going to always give you something you want to hear. This is
Yes.
why you go to a doctor.
Yes.
So
I want to hear that I can eat the whole pizza, but the doctor's not
yes,
going to say
yes,
that.
yes. How do we deal
Uh,
with that? It's an interesting problem because it is fundamentally something that the models were not trained to do. They were trained to please the user, and these reward functions were literally trying to score them on how user pleasing they are, for lack of a better word. And does this mean that the reward functions that are used to do this second level of training in the medical LLMs have to be different than just does the human like the answer or not?
yeah. So I think that there's a few ways that this is done. One is you try and introduce sort of accuracy into the metric where it decides what to say, right? So you try and so maybe one way to think is like imagine if the user you're actually trying to please is
Yeah,
the provider. So even if you're interacting with the patient, you're actually trying to please the provider.
yeah,
So this can be done by having interactions with like a patient and have them be evaluated by a physician for how good they are, and then you use that to
right. So you're saying the second stage of the training, the fine tuning stage or the RLHF stage, the labeler should actually be a provider or somebody
yes,
who actually understands the domain deep enough, right? And it can't
yes,
just be like, hey, whoever. Yeah. So that obviously that makes the whole process much more expensive. Now
yes,
you're having to employ a physician to do your labeling and fine tuning, at least
yes.
validating the results, so they can be used for fine tuning, right? So
But sort of on the one hand, on the other hand, on the third hand, also though you do need to please the patient in a sense of they need to understand what they're saying, and you
right,
still need to be compassionate in a way. The language needs to be compassionate because you're talking about people. Talking to people during like often will be a very stressful period, and and some of the advice may even be very frustrating to the patient, even if it's correct.
right.
So like the model needs to stick to its guns, so to speak, on correctness, but it still needs to please the patient in the sense of
S-
giving appropriate.
This, yeah. So this would be what you know, what's known as like bedside manner of the physician,
Yes,
right? It's like, but we all know not every physician has the same bedside manner. Some are much more brusque, and like some are, others are better, and like yeah. And yes, ideally you want someone who's more empathetic and who has a soft touch and who can deliver even if it's bad news, deliver it in a way that's much more palatable for the patient. Yeah, but obviously, first priority would be to sort of make sure you
yeah,
do no harm, right, and then provide good guidance and
yeah,
accurate guidance, and then of course if you can deliver that in a way that's much more palatable, then that would even be better. So
yeah.
yeah, cool.
So the
Um,
next, yeah, go.
yeah, so I was thinking maybe we'll move on to a
Yeah,
technical deep dive about how this whole reasoning, because you brought up reasoning. It's not just that you deliver the news, but you also want to know how and like the why, and because unlike humans, where there's sort of implicit trust with your provider, when you're dealing with a machine or a model, there's in this a high chance of hallucination and all of these things. You want to know how it actually thought through its conclusions and what was the thinking process, so you can sort of double check,
yeah.
right? So what does the paper talk about this when it comes to medical reasoning? What are the different ways that people are doing this right now?
So a lot of this is sort of similarly to in how like LM research is going current, in general, is there's chain of thought, which is sort of like the first step towards building the reasoning. So that's where it's just going from thought A to B to C in order to come to its
Mm-hmm.
conclusion.
Mm-hmm.
Um, they talk about tree of thought, so that's where um, it tries to execute different paths of reasoning. So let's say you're trying to do diagnosis assistance. So maybe at the first step it says, okay, well these are like the set of things that could explain it, and if it's this disease, okay, this is this is how we break down from there. If it's this next disease, this is how we break down from there. So it'll try to execute multiple paths, and come up with the best one towards the end. So think of this as similar to like and not to humanize it too much. I know that's a danger of these things, but like a differential diagnosis. You
Mhm.
get the symptoms. You think, oh, what are the things that this might be, and select the diseases, the conditions that might explain some of these symptoms. And they say, well, okay, if it is this disease, then we need to do this test, or it can't be that because we'd expect to see this symptom as well. Um, and then there's also the reflective decision making, and that's where you sort of have, excuse me, you sort of have the model judge its own
Right.
product.
Right.
So yeah.
Okay.
Um,
And is there like a one way of these that are better than others, or is this like still sort of a research area that people are still trying to figure out right now?
yeah, I think it's still sort of a research area. There's probably going to be better ones for certain tasks than for others.
Yeah.
Like for example, I mentioned a thing with diagnosis where essentially you're searching like a conceptual space. Tree of thought
Hmm.
is probably going to be a really good approach. However, if you need to build something that responds like very fast, tree of thought's probably going to be pretty slow.
Right.
Chain of
Right.
thought will probably be faster. Reflective decision making is good if, but you need to test it to make sure that the model can actually add value with iterations with feedback from the user. So with the model, it produces output, a user interacts with it, and then it produces new output. Um, there's a danger of either the model not really incorporating the feedback, or the model again sort of being too sycophantic and immediately changing everything to match the feedback. So
Yeah.
that'll probably change depending on the task and the user. Um,
And how does like external knowledge bases or knowledge stores like connect to all of this stuff, or does it?
well, these are all agents, so like that's something that should be to some degree ubiquitous of accessing external data. Um,
Yeah. And what are
uh,
the three ways? I guess different ways that the paper talks about being able to do that.
Yeah, so it talks about EHRs in order to access the medical history and all that. It talks about being able to
Hmm.
incorporate documents through OCR. I think that
Hmm.
sort of depends on the system it's being deployed into.
Hmm.
And then it also talks about it for multimodal systems, because a lot of these are going to have to be multimodal,
Right.
accessing medical imaging, or I imagine other
Hmm.
test results as well. But the imaging is, of course,
Right.
going to be the one most worth writing home about. Um, and so you need to be able to access these data, but also, like, let's say you have a model that's for doing for looking for anomalies in X-rays. That can be very useful, but you need to make sure that it's outputting data in a way that can then be incorporated with something that's like looking at an EHR, that's looking at the doctor's input about current symptoms. You need to be able to combine this multimodal data. So they talk about the CLIP model, which is what was it again? It was I forget what CLIP stands for, but basically there's a pre-training step to this text image model that
Hmm.
is supposed to let it produce much more relevant text to the image. Um, and I mean, outside of all this, there's also traditional databases. There's knowledge graphs. There's
Hmm.
previous conversations. Previous conversations are, they are, a source of data like from a database. Um,
Right.
so all the agents are going to need to access some external form of data. Like the only ones who wouldn't would be like maybe some super simple, question answering situations.
Right. Right.
Um, yeah,
Which I think ChatGPT probably does a fine job there. So I don't know what the point of that would be, but yeah.
yeah.
Um, cool. So maybe let's move to some of the application areas and how do you evaluate these things, right? Like to me, it's like, hey, yeah, this is all great, but like, how do I know it's good enough, or how do I know it's not gonna cause harm, especially in this sort of medical setting where it's sort of life or death? Um, yeah, let's talk about the application areas first, and then yeah, maybe
Yeah.
touch on evaluation challenges. Yeah. So.
Yeah, so as you mentioned, there's a broad ways that LLMs are being used in medicine now. Clinical decision support is, I think, like a popular one that's mentioned because there's a lot of pre-LLM existing benchmarks and studies done on that. So it seems like it seems like it should be a system we can build pretty easily because that's basically the doctor's considering someone's case and he wants to think of a testing plan or a treatment plan, and he's
Mhm.
looking for some extra data. It's basically RAG, but where the human is involved, right? That's what clinical decision support is.
Wait,
So
you're saying rag, but the human
this is
is
the model.
wrong?
So,
Is
into
the
the
model?
model. So, like in
Okay.
RAG, right, you go and do the retrieval step, and you give some extra data to the model to answer the question or the human
Uh
problem.
huh. I see.
Clinical decision support is where essentially the human is the model, and the agent's job is to find that extra information to give to the human to consider for the
Okay.
patient.
Okay. So it's a
Um,
retrieval system. Yes, is what you're saying.
yeah, it essentially is that.
Okay.
It's going to retrieve and summarize for the human.
Hmm.
Because if, let's say, a doctor is going to make a decision for a patient, um,
Hmm.
he's not going to say, "Well, the model told me to do it." He'll want a paper. He'll want something from a data. So he'll want an actual tangible thing. Say like, "Oh, I made a decision
Evidence.
for this." Yes.
Right. Okay.
Because if something goes wrong, he goes for review. If he says, "Well, ChatGPT told me to," that's probably not going to be good for his career. Um, so
Yeah. Yeah.
there's also
Yeah.
analytics and documentation. Here's actually, I think, one of the things that is I think going to be sort of a really important thing in improving the healthcare system, because this sort of like analytics and documentation, this admin level stuff, can take a lot of time from providers.
Hmm.
And that time, whereas it is useful at a population level, um, it doesn't help like an individual patient. And so the providers are stuck, having to do insurance coding or having to, document some extra details that is needed, but this takes a lot of time for them to do.
Right. Paperwork. Yeah. Yeah.
Then they talk about medical training and simulation. Um, this is going to be very complex tasks because if you want to provide reliable simulations, you need to provide more than just sort of just a random permutation on
Yeah.
tasks.
Yeah. I'm starting to see like personas, like models that are trained to become like digital personas are
Mm-hmm.
also starting. Like we talked about the role based agents. So it's the flip side of that, right? Where instead of the
Yeah,
provider role, now you have like like a patient role
yeah.
agent that will mimic the role of a patient, and then that could be used for training your like your residents or whoever who's going through some sort of an educational phase in their career, right? So yeah,
And the last
I'm
category that
interested.
they mention is the healthcare service optimization. So um, this is for things that are not necessarily required to be provided by the provider. So this is stuff like patient education, non diagnostic tasks. So this is like, um, oh, I'm not a doctor, so it's hard for me to think of an example. But like, um, I mean, scheduling I think might be an example for the
Right, right.
appointments, etc. Um,
Hmm. Yeah,
and
yeah.
so evaluation. I mean, of course, all these different applications are going to need their own specialized evaluation. But to go back to something we said in the beginning, one of the different things about evaluation is that in order to get like good, realistic evaluation, you're going to probably
Hmm.
need sensitive data to train on. So
Right,
one of the
right.
big hurdles is it needs to be done in a safe environment. Um, and there's different ways of testing. I'm working at Pacific AI now, and our tool it's all about testing and monitoring. And you really need to like consider what's the data you need to test, what are the tasks, the risks you need to test for. Um,
Hmm.
And then so that's sort of the domain aspect of testing. But then there's also the software aspect of testing. You need to have frequent testing. You need, if possible, to have monitoring to get the information about how your system is doing as soon as possible and as often as possible. Um,
Yeah.
so I know we're
Yeah.
sort of going a bit long here, but I think we're
But yeah, I think this is good content. We're covering a lot of ground, but
yeah
one of the things that just occurred to me is with the medical space, you'd mentioned, oh, we don't want the physician to get it wrong. And
yeah
usually when that happens, um, there's usually some sort of lawsuit, and there's some sort of coverage in terms of liability and insurance. I wonder how this is going to change the insurance landscape around liability insurance for providers and hospitals. Like, what if your AI chatbot said something that is considered harmful or like malpractice, whatever, and is the can you get is the same liability apply to an AI chatbot as to a human, and how do you get insurance? This is the same question that automotive industry is trying to answer now, and of course with the self driving cars. And the answer to that right now is, well, technically it's still a human behind the wheel, and they're still in charge, and they can take control of the wheel at
yeah
any point. And so you still pay, you're still liable for any damages caused when you're behind the wheel, even though the AI might be driving.
mhm,
Now, of course, a lot of the governments are starting to push back on that with more and more self-driving capabilities, where it's almost sometimes not even possible for the human to intervene. It's too quick and whatnot. And this is going to, I think, in my mind, going to raise some interesting challenges around medical AI, because there is no human behind the wheel. In some of these cases, right? Let's say you have a
yeah
user-facing chatbot. It's not like a doctor is constantly watching what the AI chatbot is saying, right? There is no possibility for them to intervene. And that's the whole point of having these AI in the first place. So it's
yeah
the liability then has to shift to either the developer of these models, or I mean, in most cases, I think it's going to have to be the organization that's
yeah
actually deploying these models and these agents in front of these patients to take on that liability, which is going to be very interesting. And this brings back to the whole evaluation aspect
yeah
of like, okay, um, how much evaluations are you going to do, and how much is it worth for you to sort of get it wrong, like, or deal with the fallout when you get it wrong, right? And
yeah
so that's the whole economics aspect of this. That's going to be very interesting as we see play out.
Yeah, I think in towards like the regulatory aspect and why I think it's important for people to get ahead of regulation when it comes to testing is that if something happens, if there's a customer facing thing and the patient, like you have a possibility of like unclear language. So the model didn't even say anything technically wrong. It was just not very clear or appropriate for the user's ability to understand, and the user harms themselves because of this. Um, you need to show that you tried your best to make the model accurate.
Right, right.
So
And that's
yeah,
where some of these chain of thought things,
yeah,
and actually monitoring and recording these conversation
yes,
histories so that you can use them as forensic evidence for a later point if needed. All of this becomes, and then guardrails to ensure that when the AI is doing something that you don't want it to do, you have guardrails in place. So the guardrails can at least stop the AI from doing something that you are obvious, like things that you don't want it to do, right?
yeah,
And those become much more important as well, right? But yeah, speaking of which, what are some of these challenges? Like we spoke about some of them, but what are still some of the major challenges you think we should, at least the paper talks about, sort of overcoming?
um, so yeah, so the paper talks about they bring up DeepSeek and some of the new ways it can be the models can be deployed. So, for example, being able to learn and improve the
Yeah,
model after deployment. So, the reason why that could be very useful is that there's certain things that it would be very difficult to fine tune your model for because it may not necessarily be relevant to all your
Yeah.
customers. So, for
But some
example,
of the technical challenges and the implementation, like the ethical
yeah,
concerns, like yeah, maybe just talk. Let's talk briefly about those as
of
well
the ethical
before
concerns,
we get it. Yeah, some of the challenges, like technical
yeah.
challenges or implementation barriers, or like ethical and privacy concerns, right? So
Um, yeah, so I would encourage you that I think maybe you actually showed this to me, but the FDA does have guidance on deploying software that's going to be used by people and even for AI.
yeah.
And there's the regulation on technology deployed that's used in a clinical setting is for software. So let's just go there for a second. Is very high and is often very exacting. And I think at this point, the reason why we don't have that level of regulation around AI is there probably isn't like the right people in the right place to write that very specific exacting regulation. But that's definitely coming. So there's also the privacy concern. There's multiple ways where privacy can be exposed. Obviously, classic, your database, right? So the database is supporting the agent that can get exposed. But then there's also jailbreaking in order to get the model to give you information. If your model has the ability to search for patients, let's say, what happens if a patient gets your system to return a bunch of patient records? Well, that's a massive
Mhm.
HIPAA violation. So when you're designing your agentic workflow, you need to think about what access different agents have. You need to approach it
Right.
as sort of aggressively as you would with like with what permissions you give to individual employees. Um,
Yeah. By the way, on that note,
yeah,
the Cloud Security Alliance, it's a popular sort of nonprofit organization that's been around for a while. CSA, they put out like a good like a framework to think about agent security,
mhm.
just around the issues you're talking about. Like, how do you think about agent security and the identity of an agent? How do you come up with a threat modeling framework? And so, sort of, they put out this agent AI threat modeling framework called Maestro,
Mhm.
and it's a pretty interesting first take, I think, at trying to take a stab at this problem that you're raising,
Yeah,
which is agents, because they have much more agency, for lack of a better word. Yeah, how do you put guardrails? How do you put more controls over it, um, and to ensure that it's not going to go rogue, right? And it cannot be taken advantage of with all these sophisticated prompt injection attacks and
yeah,
whatnot that we're starting to see more and more of. And that's going to be one of the big concerns as well, that I think healthcare organizations need to figure out before they just let loose some of these medical agents into the wild without having these things and thinking through these things. Otherwise they're just opening, because whatever security controls and frameworks they have in place, they all assume traditional software, where you have traditional ways of interacting with the software through a very well-defined
yeah,
API of some sort. And so you can control what goes in through the API, what comes out, and there's ways to sort of lock those down. But now your API is just a bunch of text, right? And
yeah,
so and you can have instructions buried within the text, and you can do all kinds of things to trick the LLM into doing things it was never meant to do. It's like, and so now, and so it just opens up all of the old sort of exploit vectors that used to exist in the early days of software are now back, because now you've just opened up this
yes,
this this whole, into your systems. And so this is, I work with a lot of like security people, and like who are really really scared about this whole thing, because they realize how easily these things can be taken advantage of, and how some of their existing controls and mechanisms and tools they've actually been using for the last few decades no longer apply
yeah.
to these sort of LLM based agent based solutions. And so this is going to be a very very challenging, or interesting, if you're in this space, problem that I think the industry, not especially healthcare, but most industries that are mission critical, will have to sort of figure out how to control
Yeah.
and prevent people from exploiting. Hey, I
That,
know we're like super over time. I don't, but maybe some
yeah.
closing thoughts on this whole thing. I think I learned a lot, but like what, yeah, let's talk about some, your closing thoughts in terms of where we are. We talked about the opportunities and obviously the challenges, but leave us some with some final thoughts on this whole
Yeah.
thing and how close are we to Baymax at this point?
Well, I would say, although like I think that there's like lots of concerns you brought up, I do think that the two things. One, we do have to go in this direction, because the strain on the healthcare system. We talk about the United States, but there's a lot of other countries who have strains on their healthcare system, and also other countries where the strain is not just from current policy, but it's just from having availability to enough doctors at all. So we have to go in this direction in order to improve availability. And I think as far as like, are we at Baymax? No, but I would also say for anyone who's watching the movie, one of the big problems Baymax had that was essentially a plot device at times was the ability was its difficulty in communicating. It didn't have complex communication. I know that's like played up mostly for humor in the movie, but being able to communicate about the healthcare things is going to continue to be a hurdle, but that's something we can definitely handle and can improve over time. So I think it's very hopeful where we are right now in terms of being able to give access to quality medical advice to many people. Um, I think that what organizations should do, though, is they should understand that there's going to be some thrashing in the regulatory space, right? There's going to be governments and in other institutions who are going to be sort of jumping around trying to figure out how to do it. The organizations that you mentioned, where they're trying to like set up regulation, that kind of stuff is probably going to be what inspires government regulation. So try and stay ahead of the curve on safety and security.
Yeah,
Yeah,
absolutely. Well, hey, Alex, thanks a lot. It was great. Like I said, thank you for taking the time and like, introducing us to this paper and like going through it. I learned a lot. Hopefully our listeners learned a lot. And yeah, and so if you're listening all the way here, thank you for sticking around. And like, please, we'll post the show. The show notes. Will Oksana will probably post a lot of the links that we talked about. And yeah, and then post your comments. We'll always look forward to reading those and any ideas you have for future episodes as well. And hope to see you in a future episode sometime soon. Thank you, everyone. And yeah,
thank you.
thank you, Alex.